There's legitimate need that exists for greater than one psychotropic drug, especially at our hospital. We have highly treatment-resistant patients who have failed multiple strategies on multiple drugs, and they're really on fourth line treatment strategies. They could be readmitted for their 10th and 11th time. So I think at our worst, we have patients who are on 3 antipsychotics, a mood stabilizer, an antidepressant if they have OCD, comorbid OCD. They could be on benzodiazepine if they're aggressive or have a lot of anxiety, and then a sleep medication like zolpidem if they aren't sleeping. So we can see how this starts to accumulate. Chronic disease in the aging population increases the need for polypharmacy. It's no secret, as we age, we start to develop more chronic health conditions like diabetes, high blood pressure, high cholesterol, as well as many other different disorders. But all these disorders can interact with our psychotropic meds as well. And it's important to understand the mechanism of these drug interactions so we can better predict these interactions, so we can better avoid these interactions, and also provide the safest care as we can and develop the strategy for the best long-term prognosis for the patient. Fortunately, most drug interactions are non-life-threatening, but they still can impair the patient's quality of life, and most highly prevalent interactions pose only a moderate risk of severity. But what do we define as severe? Like a hospitalization or emergency room visit? How about severe if somebody's having extrapyramidal symptoms and can't stop their tremor because pseudo-Parkinsonism, so they stop taking their meds and they wind back into the hospital? That's a severe outcome as well. Patients vary widely to tolerance and response to a drug combination. So if we have two interacting meds, it may really show in one patient, while in another it may not show at all. Like we had one patient who was on haloperidol and Prozac, and he was having a lot of side effects from the haloperidol. He was having tremors, he was having a shuffling gait, and when we took him off the fluoxetine, it got better. Other patients, they can tolerate those drugs without having those severe side effects. So the effects of drug interactions, there are different types of serious adverse effects. Drug interactions can affect your autonomic system, it can affect your hemodynamics, it can affect your brain, it can cause your neurologic system, it can affect your ophthalmologic system, it can affect your kidneys, it can affect hematological labs as well. So there are different types of serious adverse effects that can occur. Poor tolerability of these drugs can happen with patients, which can make it difficult to adhere to the medication regimen. I feel like every patient has to make a decision, like, is the side effect worth having, not having these voices, or worth not having mania and have to be rehospitalized or ruining my life? So if somebody's having drug-drug interactions, it can increase the risk to benefit ratio. So it can make someone not tolerant to taking the medications, or it can cause more harmful effects than good. For example, symptoms that mimic or lead to a misdiagnosis of a new disease. We had a patient who had early stage dementia. He was very resistant to psychotropic medications. He had schizophrenia too. We started him on olanzapine, which also has anti-muscarinic properties, which can cause cognitive dysfunction or memory dysfunction. So when the olanzapine was started, he seemed to progress in his dementia rather quickly. but we identified it as the olanzapine causing this side effect due to its receptor profile on how it affects the body and the predictable side effect that we could watch for because we know how the drug works. Withdrawal symptoms or drug-seeking behavior on the part of the patient. An example I can think of is codeine has to be metabolized by the CYP2D6 enzyme, which we'll talk about, to become morphine to help with pain. If someone's on a CYP2D6 inhibitor, that codeine isn't metabolized, so they aren't going to get that pain relief that they would get from the morphine because codeine isn't going to be metabolized into the morphine. So here is an example of drug interactions and adverse event cascade and how these drugs can start to accumulate in somebody. Like somebody has an increased cyclosporin level, they have cognitive changes, they have increased depressive symptoms, so we add venlafaxine. Venlafaxine can cause, due to its norepinephrine reuptake inhibition, can cause insomnia, which can lead to a sleep disturbance, so we add trazodone, another serotonergic drug. This can improve cognition and mood symptoms. Maybe when you want to start St. John's wort to make it even better. So this can lead to serotonin syndrome as well. If someone's on a statin and also lithium and they have muscle pains, they may start ibuprofen, which can increase the level of lithium and cause toxic effects. So we can kind of see how this cascade starts to occur. Like I saw a meme online once of this guy with a t-shirt and he said, my ADHD medicine causes my blood pressure to be high, so I have to take antihypertensive. My antihypertensive causes my sugars to go high, so I have to take a anti-diabetic med. My anti-diabetic med causes me to have diarrhea, so I have to take an antidiarrheal. So you see how things start to cascade and get out of control. Of significant psychotropic drug interactions, these factors we need to take into consideration and apply it to our patient to improve their safety. I can't say that enough. We want to start low and go slow. Especially in psychiatric hospitals, that can be very difficult because someone can be acutely in danger to themselves and in danger to others. So we need to figuratively throw that wet blanket on top of their head so they can improve or show signs of improvement as quickly as possible, so we no longer have to have safety precaution levels on them or require constant monitoring just so they don't hurt themselves or others. So we have to actually start high and give high dosages of drugs. And especially in these treatment-resistant patients, these dosage of drugs can go higher than what the FDA recommends or what guidelines recommend as far as being only on one drug at a time. And then another contributing factor is its concentration dependent. If a drug is an inhibitor, it'll increase the concentration of a substrate that it's affected on the enzyme, and that effect may be stronger in one person than another, so another person can show a higher level compared to someone else. And also a high concentration could cause a significant amount of drug interactions in one person, while another high concentration in another person may not cause those adverse reactions. So an example I can think of is that patients tolerate and adapt to a substantial range of concentrations. Usually they recommend for Depakote to get a serum concentration range between 50 and 120. However, some patients can tolerate and actually thrive at levels around 150 and 160. So it's not always clear cut in everybody. So if a drug has multiple pathways of elimination, the less likely a drug-drug interaction is going to affect it, because if the kidney is blocked for whatever reason, or if something is blocked in the liver to where drugs can't be excreted, then one can take over for the other. Drugs also have other pathways of elimination, such as the feces, saliva, sweat, anestology drugs can be eliminated through the lungs. So there's multiple pathways of elimination. And patients, I hate to say it, due to these potential adverse drug reactions, they exhibit substantial treatment not adherence. So if we can't have drug interactions, or if somebody's not being adherent to their medication. So that's kind of an unfortunate truth in the field. There's also opposing influences like inhibition and induction, which may be operative in the same patient simultaneously. So it can create a balanced ecosystem, and if something gets thrown off by taking away a drug or starting another drug, which can be an over-the-counter drug or even a supplement, it can end up harming the ecosystem or yourself, or the person. For drug-drug interactions, there's pharmacokinetic interactions, which consist of absorption, distribution, metabolism, and elimination. These are all pharmacokinetic interactions. And then there's a pharmacodynamic interactions. Pharmacokinetic interactions is what the body does to the drug, and pharmacodynamic interactions is a consequence of what the drug does to the body. So these drug-drug interactions, they can increase side effects and adverse drug reactions. For the pharmacokinetic interactions, there's absorption. Oral dosage forms generally dissolve in the GI tract and the small intestines. And then they have bioavailability when they cross that small intestine about which drug is, or what percent of the drug is actually absorbed. Drugs can alter the time a substance spends in the small intestine, which can affect the bioavailability. And metabolic enzymes can cause first-pass effect as well, reducing the extent of absorption and bioavailability. So if somebody's GI motility slows down or speeds up, it can affect the length of time a drug spends in the small intestine, which can affect how much it gets absorbed. So there's distribution as well. Many psychotropic drugs are highly protein bound, which suggests it can displace another protein bound drug. So theoretically, if somebody is on multiple psychotropic drugs that are all protein bound, they're all competitive for this protein and knocking each other off, which can increase serum levels of one over the other, resulting in interaction. Product labeling cautions of this interaction, but they also give a disclaimer that they are rarely a clinical concern. Metabolism. Drugs are metabolized mostly in the gut wall or liver. Psychotropic drugs are highly metabolized. Most of them anyway. Inhibitors are the most common pharmacokinetic drug interactions, and these can increase steady state or half-life of a drug, but there's also drug inducers, which can decrease steady state or half-life of the drug. Most of the CYP enzymes, which are the enzymes responsible for metabolizing a drug into its metabolites can be induced or inhibited. And then there's elimination. Most drugs are eliminated by multiple pathways. It can be through a kidney, renally, hepatically, by the liver, and saliva, sweat, feces. So the more pathways of elimination a drug has, the better compensation it can have if one pathway is impaired in some way. Here is the P450 enzyme system. It's located in the gut wall and liver, and you can see in this picture the drug moves through the gut and then passes through the CYP450 enzyme in the liver and gets recirculated back in the bloodstream as unchanged drug and also as altered metabolites, which can be active in their own self. And drugs as well, they can be metabolized by multiple CYP enzymes, and that decreases their chance of being affected by pharmacokinetic drug interactions. So we talked about this. Pharmacokinetic interactions can be caused by alterations in agents' absorption, metabolism, distribution, and elimination pathway. These can be agonistic or antagonistic or no effect. An example of an antagonistic interaction is naloxone. If somebody is on heroin or morphine or has an opiate overdose, they're stimulating that mu receptor, and naloxone is a mu receptor antagonist, so it can save someone's life, but it is a drug-drug interaction, so we're saving someone's life purposely. Most drug-drug interactions involve phase 1 metabolism, which is mediated by the CYP450 enzymes. There are 6 core enzymes that are responsible for 90% of all CYP450 activity. CYP2D6 is responsible for most of the psychotropic drugs, and then CYP3A4 is involved in more than 50% of all prescribed drugs. Kinetic interactions that we need to think of when starting any drug in any patient. First of all, we need to think about the medication and its effect on the enzyme, CYP enzyme. Is it a substrate, inhibitor, or inducer? We need to think of the potency of each medication on the enzyme or other receptors in the body. We also need to think about the drug's affinity for other receptors in the body or proteins in the blood or CYP enzymes. We also got to think about the saturability of the enzyme. We have to think about the concentration of the medication in the plasma. That's when it's really helpful. That's why it's really helpful to take like olanzapine plasma levels and flufenazine plasma levels, which we don't see in a lot of areas of practice, but we do it at our hospital. We got to know the extent of inhibition. Is it reversible versus irreversible? Is there the presence of multiple metabolic pathways, like multiple CYP enzymes, like as with mirtazapine? Is there the presence of active metabolites? Like Seroquel has an active metabolite, norquetiapine, fluoxetine has the active metabolite, new-fluoxetine. Risperidone has the active metabolite, 9-OH risperidone, are also called, I think that's what it is, but also called paliperidone or Invega. We also got to think about the therapeutic index of the medication, like there's the valproate. It has a narrow therapeutic index. Lithium has a narrow therapeutic index. Carbamazepine has a narrow therapeutic index. And genetic predisposition is another factor in how a person metabolizes a drug. A person can be an ultra-rapid metabolizer, or they can be a poor metabolizer and the drug can build up. And also sensitivity to adverse effects, such as in the elderly. we have to be concerned about, or somebody has kidney or hepatic dysfunction. I break down each of the CYP enzymes and what drugs are most common substrates. Just because a drug is in this list, they may be a substrate for another CYP enzyme as well, and they may be an inhibitor of more than one CYP enzyme or an inducer of more than one. For this slide right here, I think, at least in my practice site, some of the key drugs I think about are clozapine and olanzapine. They're CYP1A2 substrates, as well as saffrous. And one of the things about this is cigarette smoke is an inducer. So if somebody's on clozapine and olanzapine in the hospital where they don't have access to smoking cigarettes, and then they leave the community and start smoking cigarettes, they may have less of a benefit, and the patient may decompensate because they have decreased concentrations of the clozapine or the olanzapine in their system. We also, one thing to note is that nicotine is not a CYP1A2 inducer, just cigarette smoke. I'm not sure about vaping though. If cigarette smoke is an inducer, I would say vaping is as well. I'm sure they contain some of the similar compounds. And then we can see the inhibitors. Fluvoxamine, or Luvox, is a strong inhibitor of many of the CYP enzymes. It's recommended to use for OCD, but there are a lot of different antidepressants we can use for OCD that may not have such a strong inhibition on multiple CYP enzymes. We can see caffeine is a substrate for CYP1A2, so it could potentially have competitive inhibition of clozapine and olanzapine, which could potentially decrease their serum concentration or when they get metabolized. So it could increase their serum concentration to keep it from getting metabolized. And there's the CYP2B6 substrate. There's an antidepressant, bupropion. I think that's the most key thing about this substrate. As far as psychotropics being substrates of this CYP enzyme, there are not many. We have methadone, Valium, and Restoril. Paroxetine is an inhibitor of CYP2B6, so we should be careful if we're giving somebody methadone and they're on paroxetine. We don't want somebody to overdose on methadone, or even have too much diazepam or Valium, an overdose on Valium. But fortunately, we have to think. A lot of practitioners are now thinking of those drug-drug interactions and factors that go into it, and how to monitor and potentially give patients warning signs of when to seek help, of when they may be experiencing a drug-drug interaction leading to an adverse event. There's the CYP2C9 enzyme. There's nothing really remarkable about this class as far as psychotropic meds. I included it because Depakote in some reported literature is an inhibitor, and warfarin's on here, so we want to start monitoring INR when somebody started on Depakote or if they're started on fluoxetine. And actually, we should monitor INR if somebody started on any psychotropic medication because they're all highly protein bound. Warfarin is highly protein bound, and potentially these psychotropic drugs can displace the warfarin, causing an increased INR, which could increase bleeding. CYP2C19 enzyme. A lot of the antidepressants are substrates of CYP2C19. So we see fluoxetine, fluvoxamine, and paroxetine are again inhibitors. So if somebody's on multiple antidepressants, which we don't really see too much unless somebody's on like a sertraline, and then we decide to add a bupropion so they don't have sexual side effects anymore, or add on mirtazapine to help with sleep as well as unresolved depressive issues. But we don't see somebody on 2 SSRIs or anything. But it's something we got to think about if somebody's on a benzo, and we have these inhibitors as well, a benzodiazepine for anxiety. And smoking, again, is an inducer. CBD is also an inhibitor of CYP2C19. So we see CBD, I think it stands for cannabinol. I'm probably getting that right. I'm just going to say CBD. But we see that in drinks now, cabanina, whatever. We see that in drinks now. We see it in candy, lollipop, food items. These are inhibitors, and it can increase the concentrations of these antidepressants or benzodiazepines as well, which can lead to an adverse drug reaction. You can see a lot of the psychotropic drugs are substrates for CYP2D6, and a lot of psychotropic drugs are also inhibitors of CYP2D6. We had a patient who was on chlorpromazine or thorazine, haloperidol, and was also on fluoxetine all at once. So you can imagine all these drugs were inhibiting one another and increasing each other's levels. And we took all he came in on this drug regimen into the hospital, and we did serum levels. Haloperidol was way above the recommended range. Fluoxetine was way above the recommended range. We did not do a thorazine level though. And you can imagine we discontinued all the medication, and he still has medication in his system to this day. It was probably a few months ago, but it stayed in there a long time. Fluoxetine itself has a really long half-life, probably the longest half-life of the antidepressants. So if somebody misses a dose, it's usually all right. Or if somebody's not adherent to their antidepressant regimen, fluoxetine would be a good choice. But you can see there's a lot of inhibitors of CYP2D6. And here it is again, CBD. There's CBD oil. These can inhibit many of our psychotropic meds. And if someone's not careful, it can increase their risk of an adverse drug reaction. And then some sources say that CYP2D6 is non-inducible when inside the body, which makes it unique. There's CYP3A4. Again, a lot of psychotropic medications are substrates for CYP3A4. We have haloperidol, which is an inhibitor of CYP3A4. We have some CYP3A4 can be inducible, and a lot of common drugs are inducers. So we have to be aware. I just focused on mainly the psychotropics. So St. John's wort, as well as it not being good and helping in augmenting your antidepressant, it can decrease its efficacy as well. And we can see blood pressure medications can be inhibitors too, like verapamil and diltiazem. They can interact with your psychotropic meds as well. I put this on here because UGT is a phase 2 metabolism, and they mention this in package inserts sometimes because a lot of psychotropic meds are metabolized by UGT, and they warn to monitor for any adverse reactions because it could cause a drug-drug interaction, which may require a dose decrease of one of the drugs. Then there's a multi-drug resistant one-drug interaction, which is another way drugs are metabolized, and they also mention this in some package inserts, but it actually overlaps a lot with CYP3A4 enzymes. So if something is a substrate of CYP3A4, there's a good probability it'll be a substrate of multi-drug resistant 1 enzyme as well, but not necessarily if they're inhibitors. So here's a image of the first generation antipsychotics and what substrate they're metabolized by. It's not cut and dry, this one enzyme or this one enzyme metabolizes this drug. Multiple enzymes metabolize a single drug. And the more enzymes that are involved in metabolizing the drug, the less likely it is to be affected by drug inhibition of the enzyme, which we can also see in the next column is the inhibition of the first generation antipsychotics and what strength of inhibition they have on other substrates. Like for Thorazine, it's a strong CYP2D6 inhibitor. So in the third column, it gives us recommendations on what drugs to use to avoid CYP interaction. But that list of drugs is very minimal. So there's a larger list of drugs we need to focus on, not just those drugs. And then there's the major metabolic pathways for the second generation antipsychotics. This doesn't include all the pathways, like a second generation antipsychotic can be metabolized by more than one. Like you can see with clozapine, it's metabolized by CYP1A2, CYP2D6, and CYP3A4, but these are just the major metabolic pathways. One thing to note is paliperidone and ziprasidone or Geodon, they are not metabolized by CYP metabolic pathways, at least not in the majority. They're metabolized renally or excreted 100% renally. So we don't need to worry about their concentrations being changed by these CYP enzyme inhibitors. Second generations are also not shown to be inducers or inhibitors of CYP enzymes, but are just substrates, which really gives them another plus of their use over the first generation antipsychotics, because especially in somebody who has a complicated med regimen. And these are the drug interactions for the antidepressants. These are the substrates listed here, and we have mostly with antidepressants, we have CYP2D6 substrates and CYP2C19 substrates. Bupropion's kind of the oddball out. It's a substrate of CYP2B6, and mirtazapine is a substrate of many CYP enzymes, which make it less likely to be inhibited or less likely to be affected by inhibitors of one enzyme. And here is the inhibition of the antidepressants and how they inhibit the different CYP enzymes. We can see fluoxetine or Prozac is a strong CYP2D6 inhibitor, as well as a weak to moderate inhibitor of other CYP enzymes as well. Same with fluvoxamine and paroxetine. They can be inhibitors. So if we're trying to avoid drug-drug interactions from CYP enzymes, if somebody's on a complicated med regimen, maybe escitalopram or Lexapro citalopram may be one of the best options. Venlafaxine, Effexor, doesn't have a lot of interactions either, nor does mirtazapine. Polymorphisms in our population. So some patients, they may be CYP enzyme poor metabolizers or ultra metabolizers. 1 to 10% of Caucasians or 1 to 4% of African Americans, they're CYP2D6 poor metabolizers. And we saw a lot of psychotropic drugs or CYP2D6 substrates. So we may not be metabolizing those to our full effect, which can increase the risk of side effects. And then there's the CYP2D6 ultra metabolizers, which we see in 25% of Ethiopians, 5 to 20% of Turks, Southern European, and Saudi Arabian. An example of how this can become an issue is codeine is a CYP2D6 substrate. It needs to be metabolized in order to become morphine, which gives the pain control. So if somebody is a poor metabolizer, they may not get the pain control. If they're an ultra metabolizer, they may get too much and may have an adverse drug reaction. So this is where pharmacogenomic testing can really help out treatment decisions. Yeah, pharmacogenomic testing, like some of them try recommending which drugs are more appropriate for another, but they may not give their reasoning. Pharmacogenomic testing doesn't tell us whether a drug at a higher dosage would be better, or even if a drug would be efficacious at a lower dosage, at a smaller dose. A lot of testing says just avoid it. So I don't think pharmacogenomic testing should tell us what to prescribe. I think its most useful purpose is to tell us, is this patient at risk for a drug-drug interaction? And how can we manage that, and what can we do to avoid that? So here's a question regarding kind of what we went over. The key to this question, pause the video if you want to take a time out to go through it. But the key to this question is a patient is having a partial response to olanzapine 10 milligrams every evening. And he's a tobacco smoker. So he's having his partial response. What should we do? Should we switch to Seroquel ER300? Well, that's not the best answer. Seroquel is a good drug, but at the 300 milligram dose, that's not a dose they usually recommend for schizophrenia. For schizophrenia, we usually see like a dose around 800. Should we increase to olanzapine 10 milligrams BID? I think so. This is the correct answer. Olanzapine is a CYP1A2 substrate, and we saw tobacco is a CYP1A2 inducer, so he's getting this partial response. A higher dosage and more frequent dosing will help increase the concentration and increase the half-life, so hopefully he gets a full response. Adding aripiprazole 5 milligrams daily. I don't like adding aripiprazole if something's already working for a patient. As far as antipsychotics, a lot of antipsychotics work by dopamine blockade, and Abilify is a partial dopamine agonist, and it's really has a strong affinity and is potent on the dopamine receptor, so it can interfere with the dopamine blockade of other antipsychotics. So I don't think adding it is the best choice. Switch to paliperidone depot injections. That's not a bad idea if he was having trouble with adherence, but he does say he has no problems with adherence, and he is having a response to olanzapine. Who's to say paliperidone will work for him? So B is the correct answer. Question 2. Of these enzymes, as antidepressants as a group, which of these enzymes are they substrates for? You can pause the video, but the answer is CYP2D6. Another answer would be CYP2C19 if it was on there. So CYP2D6 accounts for just 20 to 30% of all drug metabolism, but accounts for a majority of psychotropic medication metabolism. Question 3. You can take a moment to read it, but I'll go right into it. This patient, he's on risperidone, long-acting injectable, 75 milligrams, and usually they give this every 2 weeks is what they recommend. And then he was started on paroxetine for worsening depression. Now, the patient is having noticeable tremors and complaints of restlessness. What could be causing this? What are these side effects? And what measures could we take to resolve them? Well, first, the side effects. The tremors are the pseudo-Parkinsonism we get from antipsychotics, as well as the restlessness. Risperidone can cause akathisia, which we also see from antipsychotics. Risperidone is a CYP2D6 substrate, and paroxetine is a CYP2D6 inhibitor. So that is which is causing the risperidone levels to be at toxic levels. So what we could do to resolve them is switch the patient to an antidepressant that isn't a CYP2D6 inhibitor, such as citalopram Lexapro or citalopram Celexa, or we could reduce the dose of risperidone. Question 4, this is either you know it or you don't. I just wanted to show you an example of a narrow therapeutic index drug, theophylline. We started fluvoxamine, and now they have increased theophylline levels. Why is this? The key to this is knowing what substrate theophylline is for, and CYP1A2 is the correct answer. Theophylline and caffeine have a similar chemical structure. They're both metabolized by CYP1A2. Those questions I got from the Stahl workbook, Stephen Stahl, S-T-A-H-L. He has tons of questions, so if you find it beneficial, go buy it. This table is just to illustrate that there are recommendations on what to do, how to change somebody's antipsychotic dosing based on the addition of a new drug. So there are recommendations, whether it's reducing the dose by 50% in CYP2D6 inhibitors, or do not use with strong inhibitors such as Latuda. But a lot of these may require dose adjustment, and we just have to be careful. There are recommendations out there, but it's not black and white. Usually, at least where I work, we add a drug and we see if there is. We're very careful in decreasing a drug, especially if it was working for someone. So we just often monitor to see what's going on if we add a drug. And then there's the pharmacodynamic interactions pathways. These are when agents alter the response of another drug. They can be synergistic or antagonistic. For example, an example of a synergistic one is multiple antipsychotics working for someone that's treatment resistant. They can work on different pathways in the body, mostly dopamine receptor blockade, but together they may be more beneficial in a treatment-resistant patient. A life-saving example of antagonism is if somebody's having a heroin or an opioid overdose, and they're activating the opioid mu receptors, and they're having respiratory depression, and an opioid antagonist like naloxone will save their life. The risk of pharmacodynamic interaction is increased with concomitant psychotropic meds. Like if somebody is on multiple drugs that require anticholinergic or hits the anticholinergic receptor, they're more likely to have anticholinergic side effects. And harmful pharmacodynamic interactions can result in severe side effects. Before we get into the pharmacodynamic interactions, let's just touch shortly on the 4 common mood stabilizers: carbamazepine, valproate, lamotrigine, and lithium. With carbamazepine, we already know it's a strong CYP3A4 inducer, so it's contraindicated in lorazepam because of that, and dosage adjustments would be required if we start it in someone on other psychotropic meds because it can decrease the level significantly. At our hospital, we probably only have 1 or 2 patients on carbamazepine out of 300 patients. Another consideration with carbamazepine is it has myelosuppressive effects, and clozapine has myelosuppressive effects too. It has a box warning for agranulocytosis, and together it can cause an even higher risk of agranulocytosis, which can result in a lethal infection. And then there's Depakote. It's kind of unsure the biochemical way that it has its drug interactions, at least in some interactions, because it increases the area under the curve of paliperidone, but decreases the concentration of clozapine. It also increases the area under the curve of lamotrigine, requiring a 50% dose reduction of lamotrigine. And it requires this dose reduction because if we increase the concentration of lamotrigine to too high too quickly, it could lead into the lethal side effect of Stevens-Johnson syndrome. And then valproate, like all psychotropic meds, a lot of them at least, are heavily protein bound, so they could displace warfarin and increase the risk of bleeding. Another factor about lamotrigine is its levels are reduced by up to 50% with estrogen-containing products. So we think about women in this population who are taking birth control and who may have a seizure disorder or bipolar disorder and may be on lamotrigine for maintenance. If they start on birth control and unaware of its effects on lamotrigine, they may decompensate in some way. So that's something we always have to have in the back of our head when talking to patients about this. Lithium, its concomitant use with NSAIDs is not recommended. They both act on the kidney, and it can have additive renal toxicity on the kidney if we use ibuprofen or Aleve along with lithium. It can also increase lithium concentrations, which we'll see on the next slide. So clearance is exclusively renal with lithium, and it possesses a very narrow therapeutic range. It's very sensitive to age, hydration status, sodium balance, and hemodynamics. So that's why we see these diuretics and these blood pressure medications, which can increase or decrease the levels of lithium and get it out of range. It can increase toxicity or can make it so it's not effective anymore. And then there's also idiosyncratic interactions with calcium channel blockers and antipsychotics. We had a patient who was on clozapine. He was tolerated clozapine really well, but he was still having schizoaffective symptoms. We started him on lithium, and he had a seizure a couple days later, and it was determined that clozapine and lithium had an idiosyncratic drug-drug interaction causing the seizure, so it resulted in us discontinuing the lithium, and the patient has not had any seizures since. So there's also antidepressant drug interactions. There's debate regarding the clinical significance of most antidepressant drug interactions. We have the strong CYP2D6 inhibitors, which we talked about already, the bupropion, paroxetine, and fluoxetine. Paroxetine is also the most anticholinergic SSRI, so we don't recommend using this in the elderly population because it can cause confusion, memory impairment, and constipation as well. Pharmacodynamic interactions can lead to serotonin syndrome, which is lethal if somebody's on multiple antidepressants or multiple serotonergic drugs, including tramadol or sumatriptan. It can potentially be lethal. It's rare, but it's something we need to know the symptoms of or tell our patients the symptoms of if they're on multiple serotonergic drugs. Inhibition of tricyclic antidepressant medications can lead to serious ADRs. Tricyclic antidepressants in themselves are strong CYP2D6 inhibitors, but they're also highly anticholinergic, and when they're inhibited, they could cause arrhythmias, convulsions, confusion, and anticholinergic effects. They're strong CYP2D6 inhibitors except for desipramine, which I've never seen used, and nortriptyline, which I haven't really seen used much either. I mainly see amitriptyline used for sleep. I don't really see tricyclic antidepressants used much. And then there's mirtazapine, which has multiple metabolic pathways. Again, we talked about that. There's the pharmacodynamic interactions of antipsychotics and what could potentially have synergistic effects on these interactions. We have the anticholinergic effects. Some antipsychotics are anticholinergics. And when we add the benztropine to somebody that's having extrapyramidal symptoms to prevent those, or the Benadryl or the trihexyphenidyl, it can have these additive anticholinergic effects. And then there's the orthostatic hypotension you get with the alpha blockers, the methyl-dopa and the clonidine, which we also see in some atypical antipsychotics as well. And then we have the QT prolongation with the tricyclic antidepressants, citalopram and ziprasidone. And then sedation with the benzodiazepines, the benztropine, the diphenhydramine, and the tricyclic antidepressants, as well as the antipsychotics that have antihistamine properties. Antipsychotics have a different receptor affinity profile, which can cause one to have one side effect and another to have another side effect. All first-generation antipsychotics have dopamine blocking activity. They have mixed serotonin blocking activity, but they say when in the body, these first-generation antipsychotics lose their serotonin blocking activity. And actually, that's what makes atypical second-generation antipsychotics atypical, because they have this serotonin blocking activity as well as this dopamine blocking activity. But we have the dopamine blocking activity, and we see additive effects, extrapyramidal symptoms if somebody's on multiple antipsychotics. But we also see that these antipsychotics affect other receptors as well, like the muscarinic receptors. You have the low potency first generation antipsychotics, like the thioridazine and the chlorpromazine, which can cause these anti-muscarinic side effects like constipation, memory dysfunction, blurred vision. And then you have the alpha-1 adrenergic activity blocking, and this can cause orthostatic hypotension or dizziness. And then you have the antihistamine activity, and this can cause weight gain or sedation. And this is just a really basic outline. There's actually 5 dopamine receptors and maybe like 14 serotonin receptors. So this is just really basic and in general. I also did this with the second generation antipsychotics, and we can see which one have muscarinic properties. We see that with olanzapine and clozapine the most. Quetiapine and clozapine, it's kind of unique with them. They have low dopamine blockade, So we actually use these in patients with like Parkinson's, where dopamine blockade will interfere with like levodopa, carbidopa therapy. So these may have their antipsychotic effect to dopamine blockade as well as something else. For example, they also use Nuplazid in those with Parkinson's psychosis. In fact, it's indicated for that, and it has its antipsychotic activity other than dopamine blockade. So that was a side note. This table also shows the alpha adrenergic blocking properties of some of these second generation antipsychotics, and if we need to think about blood pressure or if somebody's at risk of falls, and then the antihistamine, which of the antipsychotics are sedating and which can cause weight gain. And I put this table in here just to kind of summarize on a small scale how different each one of these antipsychotics are. Like you see with aripiprazole, it's a strong dopamine 2 partial agonist. Haloperidol is a strong dopamine 2 blocker. And then you see Seroquel, it has a small sliver of dopamine, so it requires higher doses to have its antipsychotic effect, but it does not have that strong of dopamine blockade as the other ones, which could make it so it has less extrapyramidal symptoms as well. And you can see the second generations have the 5-HT2A blockade, which can also help with extrapyramidal symptoms as well. And you see these a lot more in the second generation antipsychotics than you do haloperidol. You can see the big blue slivers in the second generation ones. And then here's the receptor affinity for antidepressants. Quick note is selective serotonin reuptake inhibitors also are norepinephrine reuptake inhibitors, but only to a low degree. But another thing to note is bupropion is the only dopamine reuptake inhibitor as well, so it kind of stands out from the other ones. But each of these antidepressants also bind to the muscarinic receptors. They have adrenergic receptor. They bind to the adrenergic receptors and the antihistamine receptors. So you can kind of see if somebody's on multiple drugs that bind to these receptors, they're more likely to have synergistic adverse effects because of this. The clinical consequences of blocking these receptors, so you get the dopamine blockade and you get the antipsychotic, anti-manic efficacy. And then you have the histamine blockade, which causes sedation, drowsiness, and weight gain. And you have the alpha adrenergic receptor blockade, which can cause orthostatic hypotension. It can cause reflex tachycardia, so if somebody discontinues that abruptly, it can cause rebound tachycardia, and also dizziness. So muscarinic receptor blockade, it can cause blurred vision, dry mouth, sinus tachycardia, constipation, and memory dysfunction. So SSRIs and other serotonergic drugs are related to serotonin syndrome, which is due to a serotonin excess, and there are a few absolute contraindications when prescribing drugs because of serotonin syndrome, but we have to be careful because it is a rare and potentially life-threatening disorder. Antidepressants are commonly associated with serotonin syndrome, and we also have to think about other drugs that affect serotonin like tramadol, sumatriptans, dextromethorphan for cough, which we can get over the counter, and linezolid. So We just have to be aware of the signs and symptoms. They can be as mild as itching and diarrhea to causing a full-blown autonomic instability, and it can be lethal. There's QT prolongation, and with QT prolongation, the thing we're worried about is torsades de pointes. And some drugs can actually prolong the QT interval. And when I was doing one of my rotations at the practice site, we did an EKG on everybody who was coming to the psychiatric unit because some of the psychiatric drugs do have a risk for QTC prolongation, but factors increase on high doses of medications, drug interactions, genetic mutations of metabolic enzymes causing higher concentrations of the med, and ethnicity. There's an increased risk in Caucasians. So it's important we monitor the EKG changes if patients is at risk, if they already have a prolonged EKG or if they have atrial fibrillation or anything like that. This again is a slide that a student actually did for me, breaking down the known risk, the possible risk, and the conditional risk of psychotropic meds and their effect on QT prolongation. And actually, this slide doesn't tell you whether the prevalence of the risk, it just tells you that there have been studies that shown as risky. Like citalopram is a lot more, there's a lot higher risk of having prolonged QT than escitalopram. So that's because it's due to lexapro, its active metabolite. That the College of Psychiatric and Neurologic Pharmacists created that actually tells us the extent of the QTC prolongation. We have thioridazine of the first generation antipsychotics having the most of the psychotropic drugs. I don't really see that in practice too often. I may have only seen it once. And then we have Geodon, which has a QTC prolongation of about 20. Geodon has a formulation of immediate release intramuscular formulation given when someone's acutely agitated. And we have to be sure that this medication isn't on a patient's profile to be given for agitation if they do have a prolonged QTC interval at baseline. We can also see that citalopram has a dose-dependent QT prolongation effect, and we can see how they compare to the other ones. They also don't recommend trazodone in somebody that has a QTC prolongation as well. So, because of this risk of QT prolongation, there have been warnings issued by the FDA. So, citalopram should not be prescribed in daily doses greater than 40 milligrams or greater than 20 milligrams if over 60 years old due to the QTC prolongation. So, citalopram can be used in doses up to 80 milligrams in those with obsessive compulsive disorder, which requires higher doses of SSRIs to be treated. So we likely should not be using this drug in those who are at risk for this QT prolongation and possible, although rare, torsades de pointes. So FDA warns citalopram should be avoided in patients with pre-existing QT prolongation, those who are CYP2C19 poor metabolizers, and those receiving CYP2C19 inhibitors. Then there's the benzodiazepines. The benzos have various routes of metabolism. You have the lorazepam, oxazepam, and temazepam, which are devoid of CYP enzymes, are primarily metabolized by the phase 2 enzyme UGT. However, although there aren't any CYP drug-drug interactions, there can still possibly pharmacodynamic drug interactions such as sedation, the risk of falling, drooling, Other benzos also require metabolism through CYP3A4 and CYP2C19 though. And because of this, they're affected by the antidepressants that are inhibitors at these substrates and can increase their concentration to higher than wanted serum levels, causing adverse effects we do not want. And then there's interaction with food. Some psychotropics, their bioavailability can increase with food. For example, sertraline, its bioavailability increases 25% with food. Vibrid increases 75% with food. With geodon and lorazepam, it's actually recommended in the package inserts to take ziprasidone with a 500-calorie meal and to take lorazepam with a 350-calorie meal because it increases bioavailability by up to 100%. With the other drugs, I think the key thing is to take the medication either all the time in a fed or a full stomach or a fasting state so we know what dose is working for the patient. Sapphirus, acenapine, is an example of a sublingual tablet that's placed under the tongue, and it should not be taken with food or beverage within 10 to 15 minutes. So that's an example of some of these alternative formulations we have out there, like clozapine has a orally disintegrating tablet. So we also have to be careful of when to avoid food as well. Grapefruit juice, they always tell us about grapefruit juice. It can inhibit CYP3A4. A lot of psychotropic meds are CYP3A4 substrate. Inhibition is rapid and may persist for up to 3 days as well, even after grapefruit juice is stopped. Then there's the MAOI inhibitors, the monoamine oxidase inhibitors, like Nardil. I really don't see these medications in practice, and they're only in some guidelines as fourth line for those who have extremely treatment-resistant depression or treatment-resistant obsessive-compulsive disorder. So here's a question. What food should this patient avoid if they're on MAOI to prevent hypertensive crisis? And why is it? And you can answer this. I'm going to tell you it's because of B, aged cheese. And it's because of the tyramine in this aged cheese. Tyramine in this aged cheese, these fermented foods, they all contain tyramine. On the next slide, I show a table of which foods to avoid if someone's taking a monoamine oxidase inhibitor, and which are okay. So psychotropic drug disease interaction there can also be structural and functional changes associated with aging. The kidneys, as someone gets older, there can be a decrease in glomerular filtration rate, blood flow, renal mass, and ability to concentrate urine. The concern here is the accumulation and toxicity of drugs, so maybe someone could benefit from a lower dose. And then the GI tract, there can be decreased motility, which leads to constipation or incontinence. Psychotropic drugs can have additive effects if they have anti-muscarinic properties, which can worsen constipation and can cause overflow incontinence. And there's also some reduction in acid secretion and decreased gastric emptying. So in the liver, it's the least affected by change or by age, but there's some blood flow, some decreased blood flow, size, and enzymatic activity. And there's high comorbidity with interacting disease states as well. Like if somebody has diabetes, their kidneys aren't going to work as well. And they'll be on other medications as well that will interact with the psychotropic meds. Or they may have issues making proteins if they have liver dysfunction. already or kidney failure. And then there's the pharmacokinetic dynamic interactions in the elderly. Absorption may be affected by the slow gastric emptying, potentially affecting the onset of action. If motility is increased and drug is poorly soluble, you may see decreased effects because it won't be absorbed as well. And then there's drug interactions as well that require being absorbed by acidity or gastric emptying. And then there's distribution. There's an increase in total body fat, decrease in lean muscle, and decrease in total body water. And this can alter the distribution of drugs. If a lot of psychotropic drugs are lipid soluble and they'll be stored in the body fat, so they can be hung onto for a long time and can cause reactions. They can cause a buildup of toxic reactions in the body fat. And decreased albumin in the elderly can cause more free drug, which can increase the serum concentration of a drug, leading to more adverse drug reactions as well. There's metabolism. Active metabolites can cause prolonged or toxic effects, and if these organs aren't functioning as well as they used to, we may have these active metabolites sticking around a little longer and cause a stacking effect where they accumulate. For example, some of the drugs that are eliminated through the kidney, like gabapentin, lithium, paliperidone, and clonidine, they may stick around if somebody is having kidney dysfunction. And then we all have to know the calculation of creatinine clearance, the Kolcroft-Gout equation. I don't know the name of it, but the equation is 140 minus age times weight in kilograms divided by 72 times serum creatinine, and it's multiplied by 0.85 to calculate the creatinine clearance in females. And then improving outcomes of drug therapy, we have to take all this into consideration and be able to identify the high-risk patients with advanced age, narrow therapeutic index drugs, whether they are sensitive and have prior adverse drug reaction, comorbid disease states, or low body weight or low body fat. And we have to remember drug interaction patterns, focus on the last med change, watch for new symptoms when initiating a new medication. Early effects are more likely when you add a drug to inhibitor at steady state, add potent inhibitor to a narrow therapeutic drug at steady state, or remove a potent inhibitor with a short half-life. For example, paroxetine or duloxetine is another example. Proper documentation of all meds, OTCs, over-the-counters, and herbals, and a working knowledge of CYP pathways can help improve patient care and improve patient safety of their med regimens. So in conclusion, there are many different pathways for drug interactions, and there are many situations where a drug interaction can arise. And there are many different ways and things we can do to lower the risk of this drug interaction and potentially an adverse drug reaction occurring by taking everything into consideration and always expanding our knowledge base of these drugs. We can provide the best care and also the safest care to the patients as we can, and overall provide a better prognosis for the patient with a mental health diagnosis. Thank you. If you have any questions, let me know, and I hope you have a great day. Thank you for listening. Kolcroft-Gout equation, I don't know the name of it, but the equation is 140 minus age times weight in kilograms divided by 72 times serum creatinine, and it's multiplied by 0.85 to calculate the creatinine clearance in females. And then improving outcomes of drug therapy, we have to take all this into consideration and be able to identify the high-risk patients with advanced age, narrow therapeutic index drugs, whether they are sensitive and have prior adverse drug reaction, comorbid disease states, or low body weight or low body fat. And we have to remember drug interaction patterns, focus on the last med change, watch for new symptoms when initiating a new medication. Early effects are more likely when you add a drug to inhibitor at steady state, add potent inhibitor to a narrow therapeutic drug at steady state, or remove a potent inhibitor with a short half-life. For example, paroxetine or duloxetine is another example. Proper documentation of all meds, OTCs, over-the-counters, and herbals, and a working knowledge of CYP pathways can help improve patient care and improve patient safety of their med regimens. So in conclusion, there are many different pathways for drug interactions, and there are many situations where a drug interaction can arise, and there are many different ways and things we can do to lower the risk of this drug interaction and potentially an adverse drug reaction occurring by taking everything into consideration and always expanding our knowledge base of these drugs. We can provide the best care and also the safest care to the patients as we can, and overall provide a better prognosis for the patient with a mental health diagnosis. Thank you. If you have any questions, let me know, and I hope you have a great day. Thank you for listening.